Dr. Joseph Malley is a medical oncologist with the Norton Cancer Institute. Dr. Malley has a special interest in the treatment of malignant hematologic disorders, including leukemia, lymphoma, and myeloma, as well as he's subspecialized and has an interest in the diagnosis and management of the care of urologic cancers also. He's the principal investigator of a wide array of clinical trials underway. And Dr. Malley first he earned his degree in medicine at Temple University in Philadelphia. He did a residency in internal medicine and a fellowship at Ohio State University Wexner Medical Center in Columbus. And he has a special interest in clinical trial design and management. To discuss acute leukemia, please welcome Dr. Joseph Malley.
Hello, everybody. Thank you much. I'm glad I have my voice back this year. If you were here last year, I could not speak when I was trying to do this. So nice to see everybody. Thank you to all of our pharmaceutical reps here. We couldn't talk about any of these amazing drugs that we are talking about for this disease and others without your all support, so thank you for being here. I am, as you see there, talking about acute leukemia today. It's really hard to kind of talk about the breadth of hematologic disease, malignant disease, so mostly we'll be talking about acute myeloblastic leukemia, just because it's a little bit more common and accessible to most clinicians. So I have no disclosures. Here are your topics and learning objectives for today, and hopefully we will all be experts by the end. So this slide is really cool. I think this is a picture of what a myeloblast looks like under a microscope. I remember like being a baby med student and looking at something like this and just being so enthralled by it, and it's one of the things that inspired me to want to go into management of diseases like this. But they're just really interesting to look at. And it's really remarkable that things like that can cause so much destruction and danger. Anyway, so I wanted to kind of just describe what it's like to make a diagnosis of acute myeloblastic leukemia if you're not familiar with it. So typically patients will be seen by some sort of provider, primary care, urgent care, somewhere for some sort of symptomatic burden. Usually it's very nonspecific, but the easiest thing to get in any kind of medical office is some laboratory tests. So certainly that's what happens to these people too. And usually there's some sort of abnormality that prompts usually a phone call to somebody like me or one of my partners, and that's kind of where this whole experience starts. So, my first response when I get those kind of calls is just, well, what are you worried about? Is there some sort of cytopenia that requires transfusion support? Is the white blood cell count elevated? Are you worried about leukostasis? Is there some concern for promyelocytic leukemia? Something like that, but just try to get a general sense of what is the urgency. Is it something that can be done as an outpatient, admitted to the hospital, ICU level care, something like that. So, but those conversations are what prompt the rest of the stuff that you see here on the slide. Let's see here, okay. The morphology, that's what you saw on that last slide with what the cells look like. And then somebody like me typically will order the rest of these initial tests, this thing called immunophenotyping or flow cytometry. You can see that the information from that comes back within a matter of hours or a day, depending on where you're practicing, but critical for like understanding what the next steps are. So I imagine everybody has heard of things like bone marrow biopsies and cytogenetics and FISH, all these like fancy words that we use all the time, and this is kind of where they fit in. So after you have a little bit more of a confirmatory idea that a patient is dealing with acute myeloblastic leukemia, you kind of launch the rest of these diagnostic tests. And I put it up here not so much just to tell you that's what we do, but it's really critical for risk stratification for these patients. It's becoming more and more critical as time goes on. For risk stratification, that lends itself to understanding what patients' management options are, and then thankfully, as new agents become available, they're targeting and exploiting a lot of the targets that you see listed here. So anyway, that's kind of how patients get diagnosed. So this is a slide that depicts the various diagnostic classifications for patients with acute myeloblastic leukemia. There are 2 diagnostic classifications. One's designated by the WHO, updated, I think, most recently in 2022. And then there's this other designation by the International Consensus Classification Organization. They're not in competition with each other. I typically use these things to best you try to find what do I feel like the patient needs from a treatment perspective, and how do I get them access to it? And so sometimes patients might not fit a diagnosis of acute myeloblastic leukemia by the WHO, but they do by this, so then you can access various agents because of that, or vice versa. They're not in, like I said, competition with each other, but very useful. It's also a little bit intimidating, I guess, if you're not familiar with a lot of this stuff, because there are so many disease subclassifications. But again, that's important for identifying risk and understanding treatment options. So after you've made that definitive diagnosis, here is a little bit of an overview of what the various treatment options are for patients. The first decision that you have to make is the patient a candidate for aggressive or intensified chemotherapy, or are they not? If they are, you can kind of focus in this area on the top here in the blue, and if they are not, you focus down here in the green section. So we'll talk about some of these treatment options as we go through some of the updated data here. So, okay, so let's just start imagining we have a patient that is a candidate for intensified chemotherapy. They get admitted to the hospital. They get 7 days of chemotherapy with something that we refer to as 7+3. They're in the hospital for a series of weeks, and then after all that's done and they're recovering, they get a bone marrow biopsy, and hopefully it shows some sort of remission state. About 60 to 80% of patients are able to get into remission state with induction therapy. But assuming that happens, the next phase of their treatment experience is something called, you go from an induction course to something called a consolidation course. So this is the second phase of their experience, and this is the first data that I wanted to kind of review and update with you here. So for about 40 years, the consolidation chemotherapy course that patients get is something called HiDAC, or high-dose consolidation with cytarabine. The dosing, as I was reading about this, I never really questioned it as a fellow or anything, but the dosing is 3 grams per meter squared, as you see down in the text, and that's really just been the standard for 40 years, way before I was doing this. But thankfully, some curious individuals ran this study here comparing the necessity of dosing cytarabine at 3 grams per meter squared in comparison to half the dose. And that's a big deal. I mean, these patients are really having a difficult time getting through their consolidative course. And the question was really, can you achieve the same results with half the dose? And as you can see here, just very basically, the survival curves don't drift apart much. So the answer is basically yes, you can achieve the same results with half the dose. This was just published earlier this year in 2025. There's a couple caveats to it. So patients with what's called core binding factor, acute myeloblastic leukemia, are not included in the study. Those patients do require aggressive chemotherapy with standard dosing because the cure rate is so high with standard dosing, so they're not included. But really for everybody else, in general, you can probably get the same results for consolidation if you use, instead of this thing called HiDAC, something different called IDAC. Intermediate, that's what the I is for. So, okay, so I just think this is a really important piece of information. It is now supported by the NCCN, and I intend to use that when appropriate. So another challenge, as I was alluding to, so patients that do get high dose consolidative efforts, it's really a challenging course. Very often you have to stop early. Some patients are not even candidates for it because they just barely got through their induction course. And so the question is always, well, what do you do with those people? Like, we don't have good standards if you can't kind of just march through the NCCN guidelines for like how to manage these folks. And there's been a lot of hope over the more recent years that some of the more, what's the timer? I hope I'm on time, but there's been hope that some of these new oral drugs, I got it, okay, so the new oral drugs hopefully will be able to be used, and sure enough, this study was designed to support those people, and certainly you can see here some survival curves that suggest that if you're unable to do basically standard consolidative efforts, then utilize this oral drug known as Onureg, and you will be able to support your patients in a better way with their survival experience. So another question that comes up for these young intensive chemotherapy candidates is, well, is this really aggressive chemotherapy course appropriate for all of them? It's really a hard study to do because you're talking about a potentially curative disease and vastly reducing the intensity of treatment experience that's been a standard for multiple decades. But this study was presented last year and did exactly that. It treated young, untreated, fit patients with the non-high dose chemopherapy option and utilize what we do for older people, which is venetoclax plus a hypomethylating agent. And sure enough, I mean, it's a very small study, like 90 patients per arm, but you see that by and large, the patients were able to achieve equal results with the high intensity option. So I expect that this will continue to be explored because it is so desirable to not have to really beat patients down quite a bit with the high dose chemotherapy that we've done for decades and decades. So MRD, a big concept in hematologic malignancy and certainly in solid tumors as well, but MRD stands for minimal residual disease, and it's a little bit harder to manage or measure in acute myeloblastic leukemia because the disease is quite a bit more there's more heterogeneity in AML versus like ALL or some of the other hematologic malignancies, but this is becoming more and more of a big deal. MRD in AML, depending on your subtype, that's what lends itself to collecting that type of data. This is a slide that's taken from the European Leukemia Network, and they are promoting the use of this very particular way of measuring leukemia progress in patients with a subtype of AML called NPM1. It's just a disease subclassification that does lend itself to easy peripheral blood assessment of disease status, opposed to just getting bone marrow biopsy after bone marrow biopsy. But this is a concept that's going to continue to be developed in acute myeloblastic leukemia. Another big question, so we'll transition toward the end of the discussion here to, well, what if you're not a candidate right out of the gate for aggressive intensified chemotherapy? We typically use a combination of this oral drug known as venetoclax plus another type of medicine called a hypomethylating agent. And even that's challenging to get through. You see a lot of cytopenias with these patients, and especially older folks in their late 70s and early 80s. Have a really difficult time with that. So what if you can't get through it? And this study was presented kind of describing, well, again, with NPM1, if you can find that these patients are MRD negative, meaning no evidence of disease by molecular classification, as opposed to just looking at them under a microscope, after maybe 3 or 4 cycles of this hypomethylating agent plus venetoclax combination, then perhaps you can take a break and still achieve similar results down the road by utilizing these drugs again and again at later times. So I think this is an encouraging study, encouraging data, because I certainly have plenty of people that have a difficult time even getting through this combination of, for example, azacitidine plus venetoclax. Similar to the intensified chemotherapy, if they can't tolerate it, well, are you just left in a lurch? Well, perhaps not. The oral azacitidine that I mentioned for the intensified chemotherapy patients, you could potentially utilize that as a bridge to that re-treatment effort. And that's what this study was intended to do. You can see some pretty encouraging results there. Further study is expected just because this is the age-old wisdom of just treat forever is just being challenged quite a bit across the board these days. And then I love this just because as so many companies are represented here, there are so many drugs that are being developed. You know, as you see all those different risk stratification targets for patients with acute leukemia, there are so many drugs that are in the pipeline, and those are going to be necessary to give patients the opportunity to exploit those targets in their disease. And this combination of azacitidine or some other hypomethylating agent plus venetoclax or some other BCL2 inhibitor is going to be critical as a backbone to incorporate all these new remarkably useful drugs to the therapy. Because if you try to add them to that intensified chemotherapy strategy, you really run into a ton of roadblocks with regard to toxicity. So this is such an awesome backbone because it gives us the opportunity to incorporate all of the new drugs that you're going to be hearing about over the course of the next few years. And then lastly, I just wanted to kind of focus back on this study. These patients oftentimes get left out in talks like this because it's kind of a very significant like niche zone. But patients that have relapsed disease, some of these drugs are some of the ones that are coming online or already online, and more to follow to exploit these subclassification sites such as this thing called FLT3 or IDH1 or IDH2. But just as an example, last year we had this new class of drugs targeting an entire new target for acute myeloblastic leukemia patients, targeting this thing called KNM2A, this drug called revumenib, and it's an entirely new class of drugs to target for a molecular abnormality that is oftentimes found in acute myeloblastic leukemia. And so it's just an example of all the exciting things that are to come for these patients that have a really challenging course to manage. So that is it. Here's my references, and I'd be happy to take any questions if we have any time. Yes, sir.
Young, underage, 60, which I'll argue with separately, but what do you do in those people that you don't have, they're not 79 years old, and how are you stratifying them as far as being fit? Maybe they're in their 60s, but very active, no other comorbidities.
So good questions. You know, these people that are in this in-between zone, usually like late 50s, like to mid 60s zone, where, you know, you can really tell that they're going to have a difficult time with that intensified chemotherapy course. That's where I rely on the pathologist. And thankfully within the Norton system, I mean, I know that we've spent a ton of effort on getting this accomplished, but trying to move forward the pace at which those risk stratification results become available is critical. Because if you have somebody with like a very high-risk disease, such as like a TP53 mutation or something, that you just know that high-dose chemotherapy is going to have very minimal benefit to them. If you know that ahead of time, you don't have to put them through a month's worth of intensified chemotherapy that probably isn't really going to help them much, and they're going to spend 3 weeks in the hospital. So understanding that risk stratification profile is critical for those patients to better understand if it's worth it or not to give them the opportunity for the high-dose chemotherapy. Did that answer the question? Any other questions for me? Yes, sir.
In a previous life, I saw a few patients that had AML in the elderly population. Treating with azacitidine and Clexta, quite a few of them had difficulty tolerating a hypomethylating agent. Do you see see something coming in the future where the hypomethylated agent is dropped and maybe you have Venclexta plus X background or backbone?
So I think it's going to be really hard to get away from hypomethylating agents for these patients because it has been the historical standard of care. If you were not, it was just Vidasa or Dacogen or something like that forever. So trying to back away from that is going to be really tough. I am hopeful as we get more data, like this is probably 5, 6, maybe 10 years down the road, but more data about exploiting those targets, and we know exactly how well those new drugs work, like really work. Not just exciting stuff, but like, you have a decade's worth of information on them, then perhaps we might see the hypomethylating agent kind of drift away. But I think that's quite a ways down the path. Thank you, everybody. See ya.
Thank you very much, Dr. Malley. For our next presentation, we have a duo. We have two presenters. Kayla Wilson is a nurse practitioner with Norton. She began her career in healthcare in 2014 and started working in oncology in 2016. She initially worked Norton inpatient oncology and also worked outside abstracting clinical oncology data. After graduating magna cum laude from Bellarmine in Master of Science in Nursing, she joined our group and worked as a nurse practitioner at the Norton Cancer Institute team, currently working to participate in clinical trials and helping take care of patients with hematologic malignancy on clinical trials. Kaylee Pagan, a pharmacist, is currently a PGY2 oncology resident at Norton. She completed her PGY1 pharmacy residency at St. Joseph East in Lexington. She is originally from Florida, where she grew up, and attended the University of Florida, doing both undergraduate and her doctorate of pharmacy there. Her areas of interest include hematologic malignancies, oral chemotherapies, and patient education. Please welcome Kayla Wilson and Kaylee Pagan to present Bye-Bye Bleomycin, New Advances in Hodgkin Lymphoma.
So fun fact, guys, I graduated residency a few years ago. I've just been doing this for such a long time. They still think of me as the resident, so we'll start there. So my name's Kaylee, this is Kayla, and today we are going to be saying bye-bye to bleomycin, talking about new advancements in Hodgkin lymphoma. These are our disclosures, and then next we will talk about our objectives.
So we are going to talk a little more about the need for new therapy options in advanced stage Hodgkin lymphoma.
We'll also be reviewing the NCCN guidelines for advanced stage Hodgkin lymphoma.
And then we will also talk about some recent clinical trials that have shaped the new regimens for advanced stage Hodgkin lymphoma.
Before we get started, though, let's start with a history lesson. So Hodgkin disease was first described by Thomas Hodgkin in 1832, but it wasn't until the 1960s where Reed-Sternberg cells, if you're a pathologist, you know that those are a hallmark characteristic of Hodgkin lymphoma, were first described. In the 60s and 70s, we also saw the invention of radiation and MOP-based regimens to help treat patients with Hodgkin lymphoma. And then in the 1970s, ABVD, one of the standard backbones for treatment that we use nowadays, was first described. In the 90s, we saw advancements looking at limited stage disease and also advanced stage disease, with ABVD in combination with radiation being a mainstay of treatment for limited stage disease, and escalated BIACOP, while difficult to tolerate, being demonstrated as a beneficial option for patients with advanced disease. In the early 2000s, though, we saw immunotherapy kind of coming to market here, and this is where we saw patients demonstrate benefit, especially first off in the relapse refractory setting for Hodgkin, but as we talk nowadays, or talk later on, even in the frontline therapy for advanced stage Hodgkin lymphoma.
So we're going to first talk about the need for some new treatment options in the frontline setting. And so as Kaylee just highlighted, our historical regimen, ABVD, which has been our mainstay of treatment for Hodgkin lymphoma for many years, includes bleomycin, which we all know is very difficult for patients to tolerate and comes with significant pulmonary toxicity. So that has been an issue with getting patients to be able to complete treatment without having to omit that drug in the regimen. Other important thing to note is the tolerability. Kaylee mentioned when escalated BIACOP came into the picture for those advanced stage and more fit population, but that is a very difficult to tolerate regimen. And then the other thing that we have to think about with the age demographic that Hodgkin disease or Hodgkin lymphoma targets is these young adults. So there are fertility concerns for them to be able to have children later in life. And then this also, Kaylee alluded to this too, we've used radiation as a mainstay in the treatment of Hodgkin's after that initial chemotherapy. And we know that unfortunately radiation comes with long-term complications as well, including secondary malignancies, hypothyroidism, and other cardiopulmonary toxicities down the road.
When we think about Hodgkin lymphoma, we typically think about younger patients, and we think of this as a highly curable disease. But in reality, it's a bimodal curve when it comes to diagnosis, with patients being diagnosed in their 20s and 30s. And then once again, we see an uptick in diagnosis around 50 to 60 years of age. For patients who have early stage disease, overall survival is greater than 90%, and many of these patients don't have to worry about long-term complications from progression of disease, but more so long-term complications of their treatment itself. As we get into more advanced stage patients, we see that overall survival curve drop significantly, with advanced stage disease, 5-year overall survival dropping up to 50% in those stage 4B patients. Additionally, when we think about that bimodal curve and we think about older patients who may not be able to tolerate our treatment regimens, we also see their drop in overall survival as well, as low as 58% for patients, indicating that we may need alternative treatments for patients in order to be successful in putting them into remission and keeping them in remission.
So we'll just briefly review the NCCN guideline recommendations for advanced stage disease. So you'll notice that the preferred regimens do not include bleomycin anymore. Your preferred regimens are now nivolumab or Nivo AVD and BRICAD. And so you'll still see that there are other options with brentuximab AVD, and there is still ABVD in the event that brentuximab and a checkpoint inhibitor are both contraindicated. So really just want to highlight that if you have not taken a look at the NCCN guidelines for advanced Hodgkin lymphoma, that this is a fairly recent change that we no longer are using a first-line bleomycin containing regimen.
Now we're going to get to talk about those studies a little bit. We'll start with Echelon 1. This was a phase 3 randomized trial that looked at advanced stage patients greater than 18 years of age who had no peripheral neuropathy. These patients had good performance status as well. They were randomized 1-to-1 to receive either brentuximab AVD or ABVD, randomized 1-to-1, and then they were also stratified by location and IPS score. Patients received treatment on days 1 and 15 of every 28-day cycle for 6 cycles. We looked at progression-free survival as the primary endpoint, and then secondary endpoint was overall survival, which is pretty standard for these studies. The Echelon 1 5-year overall survival data was published in 2018, and what you can see here is a statistically significant benefit for AVD in these advanced stage patients in comparison to ABVD. Progression-free survival was roughly 5-year overall survival was roughly 93% in the AAVD arm, and then 83% in the ABVD arm.
I know this slide is a little busy. Just wanted to highlight a couple of the safety profile takeaways with this study. So, of course, when we think about brentuximab, we do know that there is an increase in peripheral neuropathy in those patients, and that was observed in the clinical trial. But what I would also like to highlight is one thing that you can see is there was a significant amount of neutropenia noted in the AAVD arm, and that was later improved once they initiated prophylactic GCSF. So that is pretty standard now in that regimen that you would use prophylactic GCSF to avoid that significant neutropenia. But those were just a couple of the key takeaways in comparing those regimens.
Looking at our next trial, which is something we're proud to say that we participated in, S1826. This is a phase 3 trial looking at Nivo AVD in comparison to brentuximab AVD. Patients were aged greater than 12. Obviously, we only saw adults in our portion of the study that we participated in. Patients were treatment naive, advanced stage disease, were allowed to be on the study if they had grade 2 neuropathy or less. They were randomized 1-to-1 and stratified by age, radiation status, and IPS score to either receive brentuximab AVD or Nivo AVD on days 1 through 15 of every 28-day cycle for 6 cycles. Patients were then further allowed after completion of chemotherapy to receive consolidation radiation if appropriate based on their post-treatment PET scans. Primary endpoint was progression-free survival, and then the secondary endpoint was overall survival as well. What we have here is the 2-year progression-free survival data. The overall survival data is still immature at this time, so we can't really speak on it. But 2-year progression-free survival for Nivo AVD was roughly 90 or 93%, and then 89% for BV AVD. And what you can see here is a statistically significant difference in progression-free survival, which has really changed how we think about treatment for these patients.
And what we have highlighted here is a hazard ratio for disease progression or death in the comparison of the Nivo AVD and BV AVD arms. And what I want to just highlight and point out is that Nivo AVD was better in each subgroup. A couple that I really want to point out is specifically in those that are older than 60 years old. So historically that has been a harder to treat population, and also the toxicities with our prior regimens have made that very difficult to treat patients who are older, but this proves to be a superior regimen for those older adults, and then also significantly better in those who had, whether or not they had B symptoms. And then this next slide, just kind of some highlights from the safety profile between the two. There was significant neutropenia in the Nivo AVD arm. However, that part of that is due to prophylactic G-CSF was at the PI's discretion. And so it was not mandated. There were some differences in whether or not patients received that upfront. But it is important to note that despite that significant amount of neutropenia that was noted in the trial, there really were not significant consequences to that. There was a very low rate of febrile neutropenia, sepsis. So you may see that neutropenia, but without significant consequences or morbidity related to it. Also important to note that the immune-related adverse events were very infrequent in the Nivo AVD arm. I think when we think of our checkpoint inhibitors and these drugs that we are concerned about those immune-related toxicities, and those were not a significant barrier to proceeding with treatment in this study. And then lastly, just to highlight that the brentuximab arm was associated with higher rates of treatment being discontinued compared to the Nivo AVD arm.
The other thing we forgot to mention, radiation was not required in a high rate of patients who received the Nivo AVD arm as part of their consolidation treatment. So many of these patients just needed Nivo AVD or brentuximab AVD, and there was no role for subsequent radiation, which I think is important to consider when you think about those complications that Kayla mentioned earlier for patients, and that radiation, especially in an area that may be at higher risk for future cancers or other toxicities. It's wonderful to know that we don't have to give that radiation because of the success of these treatments. The last study that we're going to talk about, though, is HD21. This is a phase 3 randomized trial looking at patients who were less than 60 years of age, had advanced stage disease, had no neuropathy at baseline, and an adequate performance status. They did also include patients who were stage 2B, which is kind of a gray area here. We think of them as limited stage disease, but they may perform more similar to an advanced stage disease. So they were allowed to be a participant in the study, but it was a small population. So patients were randomized to either receive BRCAD or escalated BIACOP every 21 days. Initially, all patients received 6 cycles. However, at some point during the study, they had data from a prior study that suggested the benefit of using a PET-adapted treatment modality. And so patients received a PET scan after cycle 2. Depending on their Deauville score, they either received 4 cycles or 6 cycles of BRCAD or escalated BIACOP. This study's primary endpoints were tolerability and progression-free survival, but additionally, they looked at overall survival, frequency of complete response, they looked at event-free survival, and then also fertility recovery after completion of chemotherapy. This is the 4-year progression-free survival data for HD21. And what's important to note here is the statistically significant benefit that we see using BRCAD at 94.3% compared to escalated BIACOP at 90.9%. Historically, when we've thought about BIACOP, this is makes me shake just thinking about it because it is something that is difficult for patients to get through. So knowing that we have something that has modified the treatment and then also we're seeing a progression-free survival benefit from it does give me peace of mind when we think about these patients who may be appropriate for treatment. Furthermore, let's look at that PET2 adapted therapy for BRCAD patients. So what you see here on the screen is patients who are either PET negative, that would be a Deauville score of 1 to 3, or patients who are PET positive with a Deauville score of 4 to 5 after 2 cycles of BRCAD. And those patients who were PET negative had a 96.8% progression-free survival benefit in comparison to those who were PET positive. This is in comparison to escalated BIACOP. For patients who were PET2 negative, there was a progression-free survival benefit of about 92%. So we're still seeing those benefits even in patients who are PET2 negative, which I think is reassuring as well.
I'm going to spend a little time talking about the safety profile in HD21. So this trial did demonstrate that BRCAD was more tolerable than escalated BIACOP. And as Kaylee mentioned, that is something that, has been historically difficult for patients to get through, and you really have to find the right fit for someone that you think you can get through that regimen. So seeing an improved tolerability is significant for having another option for these patients. So one of the first things I want to highlight is that there were no deaths in the BRCAD arm. Secondly, still there are significant heme toxicities. You're going to see significant cytopenias with both of these treatments just due to the drugs that are incorporated. However, there were fewer hematologic toxicity related issues that led to treatment morbidity in the BRCAD arm. So although you will still see high incidence of that neutropenia and cytopenias, it did not lead to increased morbidity as it did with the BIACOP arm. Other thing that I would like to note, of course, when we're talking about brentuximab, we're still considering that peripheral neuropathy. It was important to note that even in the brentuximab arm, though it was still discontinued less frequently for neuropathy compared to the patients who received vincristine in the BIACOP arm. So although that risk for neuropathy is present in both regimens, it still caused more discontinuation in the BIACOP arm, excuse me. The other thing to note here is that the gonadal function recovery was more commonly seen in the BRCAD arm compared to the escalated BIACOP. And going back to what we highlighted at the beginning of the presentation, with this impacts a lot of young adults where that is very important to them and what their chances of fertility and having an impact on that later in their life.
So I hope you guys all understand the importance of saying bye-bye to bleomycin after listening to our presentation. We've seen a lot of advancements in Hodgkin lymphoma, specifically in patients who have stage 3 or stage 4 disease, and we have a lot of novel treatment options that can avoid bleomycin treatment. The NCCN recommends Nivo-AVD, BRCAD, and brentuximab AVD for advanced stage Hodgkin lymphoma patients. Echelon 1, S1826, and then HD21 are all of the clinical trials we discussed today that demonstrated benefit in these patient populations. And then improved safety and tolerability of these newer regimens has been demonstrated in comparison to our older agents that we were previously using. Any questions? Any takers? All right, well, thank you guys so much for listening to us today.
Thank you, Kayla and Kaylee. Justin Gorski is a gynecologic oncologist with the Norton Cancer Institute, treating ovarian, uterine, and cervical cancers. Dr. Gorski earned his medical degree from Drexel University College of Medicine in Philadelphia. He completed his residency at the Icahn School of Medicine at Mount Sinai in New York, and a fellowship in gynecologic oncology at the University of Kentucky in Lexington. He earned a PhD degree also there at the sort of same time in clinical and translational science. Dr. Gorski has a strong interest in research, including early detection of ovarian cancer and developing strategies for treating platinum-resistant disease. He received the T32 Oncology Research Training for Surgeon Scientists from the University of Kentucky in 2020. Dr. Gorski is part of a multidisciplinary team at the leading edge of treating and developing gynecologic cancers. Dr. Gorski.
Thank you so much. Those are tough acts to follow. This is my OR block time, so this is my first time attending this conference, and so didn't quite know what to expect. Those two presentations that preceded me were very detail-oriented and just incredible. Mine is a little different, so it's a little bit more surface level, but kind of introducing immunotherapy and how we're using it in gynecologic cancer treatment, and specifically where the standard of care has changed. So I have no financial disclosures, no conflicts of interest. And so let's just jump into the learning objectives here. So first learning objective is exactly how immunotherapy works and which types are used as a standard of care in gynecologic oncology. Second, I wanted to talk about who benefits the most and which tumors are actually most likely to respond. And then third, what is the future direction in gynecologic cancers as far as immunotherapy is concerned. So first learning objective, how immunotherapy works, which types are used in gynecologic oncology as standard of care. Really, if you look in the NCCN guidelines and you kind of look at what agents we're utilizing most often, these immune checkpoint inhibitors are the agents that we are utilizing all the time in the clinic. The main one that I utilize is Keytruda, pembrolizumab. Dostarlimab is also approved. These are PD-1, PD-L1 inhibitors, but also kind of moving into the standard of care, especially for recurrent disease. We do have some antibody drug conjugates, such as tisotumab vedotin and TDXD, which I've actually utilized recently in the last year or two with some pretty good success. So gynecologic oncology sometimes is kind of just, we're off in our own little world and nobody quite understands what we're doing, how we're doing it. It's complete comprehensive care for patients, right? So it's surgery, right? It's advanced, difficult surgeries. We work with the OBGYNs, but it's also taking care of patients from diagnosis through their treatment, through their surveillance. We are really a complete one-stop shop. There is no referral to surgical oncology. There is no, we are it for these patients. And so as Dr. Ham kind of mentioned, there are three main diseases that we talk about treating. Immunotherapy really is utilized in two of the three main ones. So endometrial cancer and cervix cancer. And the immune checkpoint inhibitor, pembrolizumab, and dostarlimab are the two that I had already mentioned. I don't want to spend too much time on background of what is endometrial cancer, but this is a disease process that the rest of the medical oncology world just kind of washes their hands off and sends it over to us, right? So how do patients develop endometrial cancer? Who are they? These are patients who are usually of advanced age, morbid obesity, so extra estrone from adipose tissue causes that lining of the uterus to proliferate. The amazing, and I love endometrial cancer, don't let any of my patients know that, but the amazing thing is that lining starts bleeding. So you have a 60-year-old, a 70-year-old woman who's obese, overweight, she has diabetes, and she starts bleeding. She goes to her gynecologist, hopefully she can get in within a few weeks or a month or two, has an endometrial biopsy or a D&C procedure, and then they send the referral to me when the pathology comes back. We have endometrial cancer. The reason I love endometrial cancer is 80% 5-year overall survival rate for all comers, right? That's incredibly high for a solid tumor. And so the reason is because it's all early stage disease. So why is Gorski talking about all this? Because these agents, immunotherapy agents, are really only for our advanced stage patients, right? And so pembrolizumab, the way it works, and dostarlimab, is it kind of takes off the brakes from the T cells and allows the T cells to attack the tumor. And so same thing in cervix cancer. Who are these patients? They're cigarette smokers, they're thin, sometimes of advanced age, but usually in your 40s, 50s, 60s. They have HPV, right? Potentially from high-risk sexual activity, potentially just from environment and the normal world. HIV, immunosuppressant, rheumatoid arthritis patients, any patients, right, who are on chronic immunosuppression. That's where cervix cancer starts. Again, usually we'll pick it up early, but where is our immune checkpoint inhibitors used? They're used in advanced stage disease. Pembrolizumab is the one that we primarily use. Again, it works by taking that check off of the T cells to allow the T cells to attack the tumor. So I did mention briefly a couple of these other antibody drug conjugates. Tisotumab vedotin antibody drug conjugate, so it binds to tissue factor and then releases MMAE, which is a more of a traditional cytotoxic chemotherapy into the tumor, and it kind of causes this cascade effect, killing the tumor itself and the surrounding tumors. Not used only for recurrent disease. And then, in HER2, I'm really excited about because it can be used with any, right? And I've had success with ovarian cancer patients, which is unusual, right, for these antibody kind of type drugs. But a similar idea in the fact of it's an antibody drug conjugate, not a checkpoint inhibitor. So on to our learning objective, number 2. So who benefits the most? Kind of already alluded to this, and which tumors respond. For endometrial cancer patients, it's your advanced stage, it's your widely metastatic, and your recurrent disease patients. Also, your mismatch repair protein patients, which in the medical oncology world, right, you're probably used to seeing with your GI cancers and those kinds of things. Same thing, automatic reflex, like that test, anytime a patient is diagnosed with an endometrial cancer, you'll wait 3, 4, 5 days a week, and then you'll get that report. But those patients are the ones that are most likely to respond to immunotherapy. I didn't go into the details of the landmark study that came out, Eskander et al., the New England Journal of Medicine a couple of years ago, kind of teasing off, but maybe next year, if I'm invited back, I can get into the nitty-gritty details of the trial that actually supports this. But these are the patients, when you see these patients, you're looking for that MMR proficiency status because they're probably going to respond to immunotherapy. Cervical cancers, again, locally advanced, widely metastatic or recurrent disease. I almost had PD-L1 question mark on here because, and we'll look at the guidelines shortly, but you will see that PD-L1 status is useful in certain situations. The PD-L1 positive or negative is not as profound of a difference as with the mismatch repair proteins in endometrial cancer, but it's kind of murky, something I didn't want to drill down into too much today, but it would make sense that if you're PD-L1 positive, you would respond to a checkpoint inhibitor that kind of targets that specific ligand. Endometrial cancer, So who benefits most? Advanced stage disease. A lot of people probably don't know what that means in my field, but here's kind of a pictographic representation of staging. So usually we catch these in the early stage, the stage 1A, 1Bs, occasionally involving down into the cervix, but that's kind of how the endometrial cancer spreads. It spreads down and then out and then up. And so the stage 3A to 4B patients, those are the ones who, when you see those patients, you think they should be on some type of immunotherapy. So here are the NCCN guidelines, and as you can tell, primary or adjuvant therapy, stage 1 to 4, but if you go through all the rubric in the NCCN guidelines, it points you to systemic therapy only for those advanced stage patients, right? And so right there, preferred regimen, frontline setting, carboplatin, paclitaxel, which that's the joke, us GYN oncologists, that's all we know how to use, and it's true, but now we also know how to use pembrolizumab, right? And so, because it's a preferred frontline regimen for stage 3 to 4 tumors. Dostarlimab is useful for these carcinosarcomas. So you see that little XSEP4 carcinosarcomas. So for that landmark study for pembrolizumab support for advanced stage disease, they were excluded. Another trial came out, right, included them with dostarlimab, and so practice pattern differences. I'm more comfortable with pembrolizumab. Some of my partners are more comfortable with dostarlimab, but that's really where we're bringing therapy for our patients. So which tumors are most likely to respond? Mismatch repair deficient patients, as I kind of talked about before. What does that mean, right, for some people in the room who may not be as up on the details? Essentially it means that the cells are filled with mutations, right? And so if they're deficient, you can't repair your proteins, also can have implications for Lynch syndrome, et cetera. But here's an IHC, right, showing a patient who is deficient in MLH1 and PMS2, likely due to promoter hypermethylation, but could be Lynch syndrome. So you'll wait more days, weeks, right, for that report to come back to see if you should get them over to the NCI genetics division. But these are the patients for endometrial who are most likely to respond. Cervical cancer, same idea. Tumor starts in the cervix, spreads into the cervix, and then out, right? So into the parametria. So your 2Bs, really 3s, all the way to 4Bs are your patients who are most likely to respond. And you see that reflected here in the NCCN guidelines. These are your locally advanced patients to your metastatic disease patients. Your locally advanced, you're going to use external beam radiation therapy in combination with some sensitizing platinum, carboplatin, or cisplatin. And then also you're now able to add in pembrolizumab, which has been incredible. And then if there is biopsy positive metastatic disease, then systemic therapy in combination with some individualized RT, which sometimes you'll hold on to for consolidation. But here is the NCCN guidelines, and you can see when you're in primary chemoradiation, cisplatin plus pembrolizumab right there at the top of the preferred regimen, second line or subsequent therapy, and first line therapy. PD-L1 positive tumors, right? Pembrolizumab plus traditional chemotherapy plus Bev. Second line therapy, you start getting into some of these like tisotumab vedotin, the antibody drug conjugate. And then useful in certain situations. You have TDXD down there, which I didn't draw attention to, but all right, let's see how much time I have left. So a few more minutes. So what is the future direction of immunotherapy in gynecologic oncology? And this is something, I personally, as Dr. Ham discussed, I've always been interested in ovarian cancer, right? That's the cancer that I really hate treating because usually it's diagnosed in the advanced stage, so 3C. 80% of patients, I will get them down to no evidence of disease. 80% of them, it will come back. And it's therapy after therapy after therapy after therapy when it comes back until they die of a bowel obstruction, right? That I can't operate on. And it's awful. And so bringing new drugs to these patients, bringing like there is no role of immunotherapy in ovarian cancer right now, right? This is an amazing class of drugs that we're using in all these different fields, right? And we still really aren't bringing it to ovarian cancer patients. And so, the future, I think, is somehow utilizing the immune system to attack primary peritoneal, fallopian tube, ovarian cancer patients. There are some studies that are going on, right, with combining a PARP inhibitor to increase that tumor mutagenicity, right, and to increase the damage in the cells that are evading detection by the immune system, along with CTLA-4 blockade in order to activate those T cells. And so those studies are currently ongoing, but I am very excited, right, that there's studies going on now about this. And, just to put a feather in my cap, one thing I'm really excited about is a new clinical trial that just opened with the NCI last week. I'm PI on this clinical trial, and in collaboration with Regeneron, we are now almost, I think it's officially open, but we're still working out some of the kinks as far as the logistics of inpatient admission for patients who go on this trial. But it's a phase 2 study using a BiTE, a bispecific T cell engager. And so that's where you can take this bispecific antibody, so an antibody that binds to two different things, one thing, a T cell, as you can see there on the left, and try to pull it to those tumors, right, and activate them and use the T cell to kill the cancer. And so CA-125, which a non-GYN oncologist in the room may have heard of, right, is a tumor marker that we follow that a lot with our low-grade serous and our high-grade serous patients. And usually it kind of shows you what's going on as far as response of their disease to different treatment regimens and things. But that's what this BiTE, this bispecific T cell engager binds to. It binds to MUC16, which is your kind of homolog to CA-125, and it pulls and activates these T cells. And so you'll initially have this pretty profound immune response, which can be difficult to manage clinically, and so these patients need to be admitted to make sure that they don't have activation. And this is new to us, right, as GYN oncologists, or carbotax surgery. And so we're kind of working out the kinks, but I know that others in the community have been using BiTEs for quite some time, and so we're excited to collaborate with the medical oncologists who may have more experience with this and bring this type of thing to our patients here.